Margaret?
A comment as co-chair and then a question. We've been really disciplined in all of our previous meetings about ending at 11, and I think I'm going to give you an early warning. I think we might run a bit over 11 today, and I hope that's acceptable to people. The question, though, David, is Charter Oak is not a Medicaid program, right?
No.
So Shaler and Aetna and all those places will have to stop calling themselves Medicaid only.
Well, it's not Medicaid now.
Well, it's not Medicaid now. That's not really my question. That was a comment.
In the future, it might be.
But since it's not a Medicaid program, it doesn't face some of the same restrictions federally around coverage for people who are undocumented. And certainly from where I sit and the many people who come to the doors of our community health centers, there are a lot of people who can't qualify for Medicaid on the basis of their citizenship status, although they would qualify on the basis of their finances. And we see this with certainly the prenatal population, as Sharon and I have discussed, but also with adults and kids. Is there any consideration or discussion going on about allowing that group to participate in Charter Oak since it's not federally restricted? It seems to be more of a policy decision at the state
level. There's a lot of discussion. Where we're at right now is we will allow non-citizens who are permanent residents under cover of law, which means they are legally here, to participate. We are not going to enroll people who are undocumented.
Randy. I didn't see anybody else.
Thank you very much. That certainly improves my understanding from what I had on the web surfing. But from the web surfing, I have an introductory comment, and then I have a couple of yes/no questions in hopes to speed it along. Looks to me like reality dictated some changes in the program from initial announcement to the final design, most particularly in that the initial announcement said there would be no $100,000 limit. There would only be a lifetime limit. But that the reality is that trying to get by on about $50 a month state subsidy, you're $11 million for the target of 17,000 people, you had to make some trims. Is that approximately right?
Yes.
Okay. And those numbers are about right. It's about $50 a month.
From the client.
From the state.
Yeah, well...
Because it's 75 minimum from the client.
It depends on the income band.
Right.
The balance between...
But on average, that's what the
it's close.
Numbers suggest. Okay, thank you.
Just a couple questions, David. Do you have enough information yet to share about, of these income bands, who at least initially is trying to come onto the program?
I don't know.
Okay. Is that, at some point, if you could share that with this group, that would be really helpful information. And to what extent, like you said before, the same experience we had with S-CHIP and Husky B, to what extent we're actually sending people over to Medicaid or...
Yeah. We'll be able to report all that out probably by September or so, but right now I can't do that.
The other question I had is, I thought, I could be wrong about this, that you all were going to issue, were you going to issue regulations?
We are.
And when might that happen?
Very soon.
Very soon meaning tomorrow? Or no, I'm kidding. Do you have a outer limit of, you don't know?
You're really asking some tough questions today, Sharon. I don't know. I mean, my deadline was that they would be issued last week. I guess I didn't make that. But I know that people are working very hard back at the department today to try to get them out before the end of the week. But I don't want to promise a day.
And will that follow the same procedure that there'll be proposed regulations that will be implemented immediately, but there'll be public comment?
Of course.
Okay. Of course, no, I know there'll be public comment, but you're going to implement as a proposed regulation?
Yes, we are.
Okay, thank you.
Nikki?
Just a couple comments. First of all, with all of the transition going on with Medicaid, and I think the department is to be commended for what you're trying to do here. This is an enormous task, and I think you've made it a great initial start here. I think that everyone needs to appreciate the fact that this indeed is a huge challenge, and it was never meant to be a be-all to end-all. And I think clearly I'm familiar with the struggle you must have gone through to try to manage the benefit level to make this thing affordable to the individuals and also affordable to the state of Connecticut. If there's any counsel I would give is that everyone needs to appreciate that this is a toe in the water here. This is not a be-all to end-all, and I would encourage the administration not to try to overpromise here and then end up under-delivering. I mean, that's just a general rule. I think we all have to accept this for what it is. The other thing is more of an actuarial concern that I've had from the outset, and I've done an attempt here to try to compare the Charter Oak rates and benefits to what you can purchase in the private market, assuming you're insurable. And the problem I'm finding is that it seems like older folks are clearly advantaged by coming into the Charter Oak plan, but a lot of younger people can probably buy this insurance more cheaply on their own through private means if they're insurable. And so what I worry about over time, even though, believe me, I'm supportive of what you're doing here, is that this pool may be problematic in the long term, and that it may have people with higher health care needs than are supported by the rates. And I just wonder if you choose to comment on that.
Well, that's really, there's a lot of things that can make and break this program. And, you know, there's the old axiom, no good deed goes unpunished. I mean, you can try to do this and it may not work out exactly the way that you planned. I think the problem that a lot of bold state initiatives have run into, whether it's the Dirigo Health Plan up in Maine or some of the others, is exactly what you're talking about. That you try to design a program and you assume actuarially a mix of a younger healthy population and people coming in who have chronic illnesses or just very expensive individuals. And if those enrollment projections don't pan out, yeah, we're going to be in trouble. But that we took our best cut at it, and that's kind of where we are today. But yeah, I mean, that is the concern. There's no question about it.
What is the analysis and the assumptions in terms of the market makeup that you have in terms of a healthy versus not healthy, young versus old?
We're certainly hoping that we're going to be enrolling a significant portion of the take-up rate amongst, younger, hopefully healthier individuals who are going to be buying on as post-college or first job types of folks. We're hoping that's where our take-up rate's going to come. If it turns out that it's not, then Mickey's concerns are very valid.
Paul?
One quick question. Thanks for the presentation. The dollar amounts, the premiums that you had in that chart, the scales on the FPL, are those premium dollar amounts fixed right now, or are they indexed on an annual basis to go up?
Well, they'll be renegotiated next year.
So the premium dollars there will potentially reflect future trend in medical costs?
They'll have to.
Okay. Thank you.